Hi, this is Margaret Martin at Mueller Guide, and I have recently been asked to give a talk for the Ottawa chapter of the lymphoma support group. And the title of my talk was, as you see here, Healthy Bones, the Inside Story, the Impact of Exercise During and Following Cancer Treatments. And the talk was so well received, I thought I would share it with my listeners as a blog. And so the talk we had was an hour in length, and I do realize that it's a long time, and so I've broken it up into two sections. Just so that you know what the two sections will be covering. In section 1, understanding bones, and this is really good information for anybody. It's all general information on bones. And in section 2 will be more specific to cancer care, where we'll look at exercise considerations, contraindications and precautions, getting started, and exercise guidelines. So, under section 1, or part 1, understanding of bones, we'll cover the functions of bones, the types of bones that we have in our body, what type of bone cells we need to be concerned about, the definition of bone remodeling, the influences of bone strength, how do we go about measuring bone, and how do we build bone. So, functions of bones. I have here two images, and this is a cross section of a femur, which is the long bone of the thigh. This top part is what is referred to as the head of the femur, the neck of the femur, and the shaft of the femur. Here you have a magnified image where you start to see the bone on a more cellular level with veins and arteries going through the bone. So the functions of bone. Well, we all know bone is supporting the structures in our body, protecting our internal organs. So the ribs surround our liver, the top of our stomach, our heart, our lungs. Bones are very critical in movement. They're important attachment points for our muscles, allowing leverage around joints. Bones also play a very important role in maintaining mineral homeostasis within the body as a place for blood cell production, as well as a storage site for triglycerides. Types of bone. As you saw in the first image, there is this picture of the femur, and you had this hard outer shell here, and then on the inside, what looks like more of a spongy type bone. And so those are the two types of bone. We'll go into them in more detail. The outer firm bone that you see is referred to as cortical bone or hard bone. It makes up a greater proportion of the peripheral skeleton, peripheral being the skeleton of the arms and legs. It is a 3-layer protective outer shell around every bone in our body. 80 to 90% of the volume of cortical bone is calcified, hence it's very hard bone. And it makes up 80% of our total skeletal mass. So it provides us a significant amount of weight in its presence. And so that is one of the reasons people often ask me, why do we have the softer bone? Why do we have that? Is that it's not as heavy. So the cortical bone is good, but it is a heavy bone. If we were completely cortical bone, we would be a lot heavier than we are. Cortical bone has a slow turnover rate, has a high resistance to bending and torsion. It provides strength where bending would be undesirable. So if you think about areas of the body, you're jumping, you don't want a lot of bending in the long bones of your lower legs, your upper legs. When you're doing push-ups or taking a lot of load through your upper body, you don't want your humerus or your radius and ulna to be doing a lot of bending. that shock absorption is the role of the softer bone within our body, or trabecular bone. So here you see the image of spines and each individual spinal bone. The top spinal bone is portraying a healthier bone where you have a multitude of little tiny openings amongst the scaffoldings of rods and cones, as they're referred to, little vertical and horizontal structures or scaffolding. And within the context of today's talk, when cancer starts to affect bone in the same way that lack of estrogen or other nutrient deficiencies or medications can affect bone, you start to get an erosion of the trabecular bone. So here you see a bone that is becoming more osteoporotic, and here's a very extreme osteoporotic bone with an actual collapse of the outer shell, or that cortical bone getting collapsed or compressed. So this trabecular bone is our interior scaffolding. It's the interior scaffolding that I'll point out of certain bones within the body. Only 15 to 25% of our trabecular bone is calcified, so it's actually very soft. And like our disc, as you see here between every vertebrae, it acts as a shock absorber. It makes up 20% of our total skeletal mass, so the good thing is not nearly as heavy, but it's 80% of the bone surface. So it covers a lot more ground, and as a result, is in contact with more substances, nutrient-wise or health-wise, than our cortical bone. So it constitutes most of the bone of our axial skeleton. And that's the bones of our skull, our ribs, the spine, and the neck of the femur, which was the part between the shaft and the head that I pointed out earlier. So here you see a skeleton demonstrating the relative proportions of cortical and trabecular bone. As you can tell in the top, the area of the thoracic spine, or mid-back, has one of the highest areas of your body of trabecular bone, or soft bone. As you get lower down into the spine, there's a little lower percentage of trabecular bone, but still quite high in comparison to other parts of the body. The pelvis, for instance, is approximately 50% cortical and 50% trabecular. The neck of the femur, I mixed my numbers up there. The pelvis is 25% trabecular, 75% cortical, whereas the neck of the femur, which is a high fracture site, is 50% cortical and 50% trabecular. So, different parts of the body that has more trabecular bone is going to be more susceptible to fractures. This is where the understanding of bone remodeling becomes important. So why do bones become more susceptible? Well, bones undergo something called bone remodeling, and this is the sum total of bone resorption and bone formation. So you have bones that are constantly being reabsorbed or replaced, and new bone being formed. And this is really important because otherwise we would all have bone growing older and no replacement happening. So the function of bone remodeling is that you're getting a constant repairing of micro damage. You're getting a reshaping of bone to accommodate growth and mechanical usage. So if you take up a sport, and this is especially true in your early years, where that sport is providing you with constant impact in your legs, and your body's going, wow, Janina's really working hard in her legs, and I really need to be ready for that hard pull from her quadriceps on the femur, and I'm going to really strengthen this up. Or you're skipping rope, and that constant impact, those kind of things stimulate the bone, and the bone does reshape to accommodate that growth and mechanical usage. Another function for bone remodeling is that it provides the body with a source of calcium, and that calcium always allows the body to have that reservoir so that the extracellular calcium levels are maintained at a healthy level. Bone remodeling takes time, and the actual process of taking over old bone and building new bone can take up to 200 days. Insofar as bone turnover of the entire skeleton, that can take between 8 and 12 years. So the rate is somewhere between 8 and 12% per year. So bone resorption, here is an image to help you understand it a little bit better, but you get these osteoclasts, which are ruffled bordered cells. The clasps help you remember the C, that they are cleaners or cutters of bone. They release acid. They look like little jellyfish, that's how I remember them, that release acid into the bony tissue, and it dissolves the minerals. So this has its own time frame, approximately 2 weeks of cleaning up the old bone. And then you have the formation phase, where now that there's a nice cavity that's been formed, the osteoblast, or the builders of bone, can come in and start to fill in the cavity. And that can, take a total of 3 to 4 months before that's filled in, and then, the whole cycle is repeating itself, but it's repeating itself on a constant basis. So what are the determinants of bone health that ensure that, our bones are staying healthy and they're remodeling at a healthy rate? Well, there's quite a few determinants of that. One of them you have no control over is your genetics, at least insofar as the way the world is today, we have no control over. The other one is your nutritional intake, your alcohol intake, whether you have food sensitivities, allergies, all of that will affect your ability to absorb nutrients. Your activity and exercise is very much a determinant of bone health. As I mentioned before, how the bone remodels based on the activity that is being signaled to the bones by the muscles pulling on the bone, by the impact of the bone on the ground. And then, and very importantly, hormones play a very big role in the determinant of bone health. And this is especially seen in the amount of bone growth in the years surrounding puberty. So in the 2 to 3 years surrounding puberty, girls and boys will build approximately 26% of their entire bone mass that they will have in their adult life. So the combination of the hormones, and if they have an optimal level of activity and nutrition during this time, that can really set them off for a good start in life insofar as their bone health. And lastly, in terms of determinants of bone health, is medication and well-being. And since this talk is focusing on cancer survivors, the medication that I will talk about is based more on cancer survivors. So there is cancer treatment-induced bone loss, and that is a very well-known term for the bone loss that occurs because of the treatments that are currently used for cancer. Chemotherapy, we know, causes reduced bone mass. There's CMF, which is an abbreviation for 3 anti-cancer agent formula that has been shown on these things are life-saving or can be life-saving, but unfortunately their impact on bone is that it does have a shown reduction of bone density up to 6.5%, which is not recovered once chemotherapy is stopped. Tamoxifen, we know in premenopausal women increases fracture risk by 32% after 5 years. In postmenopausal women, tamoxifen actually has a protective effect on bone. And cancer treatment-induced bone loss is most commonly seen in patients with breast and prostate cancer who receive the chemotherapy, hormone therapy, or surgical castration. Obviously because of the double effect on hormones, which was one of the big areas that we spoke about earlier. And then low bone mass is found in patients with lymphoma treated with corticosteroids, radiation, or alkylating agents. There is a long list of other medications that affect bone, and I didn't have room in this talk to give that to you, but if you go to the NOF website, they do have a long list of medications that affect bone. So how do we know what our bone status is? Unfortunately, right now, the only tool that we have measures bone density and not bone quality, and that's an unfortunate thing, but so we do look at bone density done through a DEXA, bone mineral density test, is read in grams of bone per centimeter squared. Your T-score and your Z-score are two numbers that you will often receive. Your T-score quantifies the difference between your bone mineral density at your current age and the peak bone mass for a young, healthy person. So you're being compared to somebody, usually a female, at their peak, so roughly at about 25 years old. And the Z-score quantifies you between your bone mineral density at your current age and the peak bone mass of your peers. So it's comparing you to your peers. Now, bone density is just one part of the equation. Bone quality is the second. Bone quality is the ability of your bones to resist a fracture, because we know that some people with good bone density might have poor bone quality and therefore still fracture. So bone quality is unaccounted for in bone mineral density measurements. It's the sum of all the other characteristics of the bone. So what type of mineral matrix deposit happened? What kind of collagen? What is what have the bones been exposed to through exercise, through movement, through impact? Those are the things that will alter the quality of the bone. So what are the consequences of poor bone strength? Well, one is obvious, and that's fractures. And not all fractures lead to pain, but they do certainly lead to limited movement and reduced quality of life. And where are the most common fracture sites? Well, if we go back to looking at the types of bone, the areas in our body that have the more trabecular bone will be more impacted. So the spine, our wrists, our hips, and for individuals that are cancer survivors or facing the diagnosis of cancer, the location of bone metastases is also a consideration as a potential fracture site. So a couple of slides here on spinal fractures. They are more common than hip fractures, and over 5 years the incidence of death is as high as somebody with a hip fracture. But the thing is, if somebody gets a hip fracture, they get a lot of attention, and our medical system is set up to put them on the fast track to rehabilitation and being mindful of their bones. But unfortunately, most spinal fractures occur silently, and therefore sometimes people have pain, 50-ish% don't have pain, and they occur silently. You might have a little backache, but then you're still at a high risk for a second and third spinal fracture, which is why over 5 years the multiple spinal fractures increase your incidence of death and decrease your longevity. So insofar as keeping your spine safe, and you'll see a lot of information on Mueller Guide about protecting your spine, learning not to bend at your spine where you'd be compressing bone that's already potentially weakened, but rather bending from the hip, from the knee, and keeping your spine in good alignment throughout all of your daily activities is so very important. Bone is living tissue. It requires mechanical stimulation to remain healthy. So the last thing I want you to do is get a diagnosis of low bone density or osteoporosis, or you have a diagnosis of cancer and you're concerned about your bones, as well as so many other things to be concerned about. But your bones need you to stay active. Bone cells are responsive to mechanical signals. When a load or stress is applied to bone, bone is deformed, but it should be deformed just enough that it stimulates the bone and not breaks the bone. So this is where working with a healthcare professional that is aware of your health status and is able to gradually implement the stresses into your body so that you get a progressive increase in loading to keep you safe, but to get you stronger is so very critical. So what are the key bone building principles? Site specificity, high mechanical strain rate, weight bearing, novel patterns of bone loading, and loading frequency. We'll cover each of these. So we know that exercise's effect is very site specific, meaning that exercises for the upper body will not impact the bone strength of the lower body and vice versa. We also know that mechanical loading is good. Loads that contribute to bone building are things like gravitational forces, muscle forces, ground reaction forces. We just need to find the right forces to keep your bones healthy, and keeping them healthy, keep building them, but keeping them safe from fracture. So with that, although we know that high mechanical strains are very good for the bones, and that high loads with sets of 8 to 12 repetitions in the 70 to 90% 1RM range has been shown to be very good for bone. Having said that, I would never start somebody who has been deconditioned for months or years on that mechanical strain load. So you would want to start with lower loads, higher repetitions, gradually building into the load that we know helps to build bone. We also know that running and jumping induce great ground reaction forces, so much so somewhere in the order of 3 to 6 times our body weight, but it doesn't mean that everybody's ready for it. So we want to load the body in a safe and progressive manner. Weight bearing, we know, is better than non-weight bearing when it comes to bone health. And so weight bearing exercises are more effective for in the density of the bone. But if you are in a situation that the only exercises you can do comfortably are non-weight bearing, cycling or swimming, I would not ever discourage you from doing those things because there are so many other great benefits, but you would do them in view of gradually getting in more weight bearing as time progresses. And then when it comes to patterns of loading bone, you want to have novel patterns, meaning doing different things as much as possible. So if you love to brisk walk, great, but challenge yourself with maybe hitting a few of the staircases en route and going up and down stairs, or doing crossover steps, or taking up a dance class so that you are introducing different patterns of loading on your bone. Going up hills, down hills, these are all great ways to load your bone. And when it comes to weight training, there's hundreds, as you've probably noticed with magazines and the media, that there's always a new way to stimulate, the biceps or the your thigh muscles, but you want to make sure that you're doing it in such a way that is safe for you. But changing things up is a great thing for keeping things interesting, but your bones really enjoy it as well. And the loading frequency, and I get this a lot, when people say, do I have to do this all at once? And I say, no, it's even better if you can break it up. So mechanical loading protocols are more bone building if your load cycles are divided into several discrete bouts. So you might go for a brisk walk in the morning, do your weights before lunch. If you, and I'm assuming, I'm saying this protocol for someone who's retired or on holiday, or you might, slip in a brisk walk at lunch and, do your weights before going to work, those kind of things. So just breaking it up, even we know that, several hours of separation. Just remember that if you're, doing an exercise protocol that requires a warm-up, that you'd still allow yourself a few minutes of warm-up before going into it if you have had several hours of rest or break in between. So, talking about a break, if you are wanting to take a break, this is an opportune time. But some of you, are really anxious to get into part 2, or section 2, I should say. So I don't want to keep you hanging. But I am going to pause here, and you can go right into section 2 of the blog. And thank you for tuning in to Amelia Guide for section 1, part 1 of the blog on cancer and bone health.